Great day.
It was a great day.
Yeah,
and a great
couple of
conference
days.
as well. But we're not finished yet because we still have a lot of things to discuss in here, of course, because our web audience is still here joining us for the last discussions with two very amazing people that I have a lot of questions for.
And I love this dynamic because we're really looking at what's going on in the US, what they're doing right, what they're doing wrong, where do we see that, and what Finland is doing as a really, really innovative approach to healthcare and what you're doing. So let's start off with the US.
Sure.
We talked a little bit about during your session about, I started off having governmental healthcare, the best healthcare in the world, where the cost was really equal to what Scandinavians or people in the Netherlands, where I live now, pay, but you have a speed and choices that are just phenomenal. You can have tests done same day, expensive tests, fMRI, MRI, that kind of thing, and just because it will put your mind at ease, just because your doctor wants to make sure everything's okay. I mean, that has to blow people's minds in the rest of the world.
So I think there are two very important pieces to understand.
Yeah.
And I would not argue with the basic premise. If you have the Federal Employee Health Benefits Plan, that is the best situation to be in, hands down. The absolute creme de la creme of high quality care paid for at the best price the government can negotiate. Absolutely, no question. But the only reason that's possible in the United States is because of an effect we call cross subsidies.
Okay.
And that means that a lot of other people, mostly the employers on the slide that I showed, and other private entities are overpaying so that the government can underpay.
Yeah.
And what that means is it would be wrong to think of it, I think, or I would be mistaken if I left you with the impression that it's a deliberate distribution mechanism. It's not deliberate. It's something we didn't anticipate that just came up.
But it's splitting.
But it's splitting, exactly.
Yeah.
And which leads me directly to the second piece. We like to say in the United States that we do not ration care, that national health systems ration, because you can't possibly pay for every single possible thing in every instance up till the minute of everybody's life. Nobody has the time and treasure to do that in a functioning nation. So we say in the US, we don't ration care, and if we had a socialized healthcare system, if we had a national healthcare system, we would have to ration. And this is me speaking as Amanda, not on behalf of the United States of America, but my analysis is that we do, in fact, ration in the US. What happens is if you're poor, you don't get care. Now, if you're very poor, you get a state-based program called Medicaid, which does give you access to care. But if you're hovering right above or in poverty, you don't qualify for Medicaid, but you don't have access to private insurance because you can't get a job or you can't afford the premium, you get nothing. Nothing. You go to a hospital, they have to stabilize you, not fix your problem, but stabilize you. Then they put you back out on the street, and you just cycle through that until death or disability.
And so we're seeing sort of a separation of classes where the rich, not only, because let's talk about food too, organic food, healthy food is much more expensive in the US. And so the wealthy are getting great care, they're getting good food, they're getting access to health and nutrition and wellness, and poor people are being put into this situation where they're getting bad care, they're getting worse food, and they're just not getting the same offerings.
I'm not sure they get bad care. I think they have problems accessing any care at all.
Yeah.
Yeah, exactly.
That's better to say.
Yeah.
I think I want to go a little bit further into that, what you were mentioning. When you're looking at healthcare, and I gave the production team a slide that I recently found on the internet. I hope they're still here with me. I think they're not listening.
Are they serving cocktails
no, they're
already?
not listening, but hopefully they can show me this slide. Oh, there it is. This is a monthly usage of diabetic materials. As you can see, the prices of it is quite high. You're speaking about roughly $1,500 per month that a diabetic has to pay. Now, I understand that when you're looking at the healthcare system in America, there's the Affordable Paying Act?
Care
Act. Which ensures that even chronic patients have access to care. But isn't it normal that a government like the United States that has the responsibility over so many people also uses its leverage, its power to push down the prices of these things? Because if you compare the prices of, let's take the box of insulin that is down at the left corner, $671. In Europe, the price is not getting over $200 because governments force pharmaceuticals to keep the prices low because otherwise they will not buy it anymore from them.
Well, this brings up things like the EpiPen, the rise in
Exactly.
the EpiPen costs,
Yes,
Monsanto
medications.
and Bayer merging, which is very scary in my mind.
But that is something that is crossing. We were both discussing that actually as well. That is something that I'm wondering about. Does the American healthcare system not want to put leverage on pharmaceuticals? Does it not want to guarantee that a diabetic can take its insulin, or has to decide whether or not to take medication because they cannot afford it?
Well, I think one of the key messages that I was trying to deliver is that the U.S. healthcare system, let's just take the U.S., 50 states, 350 million Americans, the size of a continent, and fundamentally a representative democracy. So you have an enormous territory with a very multicultural society that you have to administer using the principles of federalism, right? So the American culture is not necessarily one of strong central economic control from the federal government. We just don't operate that way. It's not part of our history. So that's one piece. The second piece is the United States healthcare system is private, public, and nonprofit. It's over $3 trillion. It's not very helpful to think about it wanting to do something or not wanting to do something. It's a monster, and it has a ton of unanticipated consequences just by existing every day. And because there is no central regulatory function, or there is no one hospital system or one organization that employs doctors or one drug company, it's many actors acting rationally in a system that produces these negative effects. So you can't really ascribe motivation, which I know you weren't trying to do, but it's important to understand in thinking about smart solutions to the problem, because you can't just find one bad actor or one bad regulation, fix it, and then you have an answer. You have to change the system so that it produces the outcomes you want. Okay, so how do we fix this? So specifically to your question, we are trying to think about the ways that people with chronic diseases can manage that in a way that doesn't make them broke. That would be good, right? And in a way that they can be accommodated by an excellent healthcare system. My colleague, Robin, who spoke on the first day in the opening keynote, she would actually be a much better expert than me through her personal experience to speak to that. But I will say one of the complexities around the high cost of drugs, and this is actually an issue that we are attacking politically in the US, but one of the issues there is many, not as many as they used to be, but many of the drugs and devices that are used for chronic disease are actually developed in the US. And if something's going to be developed, it takes 10 years of plugging money and failing in the laboratory experiments and having to go through a regulatory system before you even see a yield on that drug. Once it's on the open market, other countries can take advantage of it, and they can use it, and they can prescribe it, and they can pay for it in a million other ways. But in the cost of that drug, they don't necessarily have to account for the cost of its development. We do. Now, are there drug companies that sometimes wildly take advantage of that? Absolutely. Mylan is a great example. They didn't develop that particular chemical. It's epinephrine. We've had it for a long time. But because of the packaging and the way it works, they have a patent and it works. But these are systems that were developed for rational reasons, to encourage companies to develop groundbreaking drugs, particularly in molecular targeted therapies for cancer, very promising. Instead of trying to kill cancer drugs, we're going to work with the body's immune system, much less poisonous, much more effective. But in order to encourage companies to invest in that, we have to give them price protection on the other end. There is a better system out there, but that's the one that we have, and it produces the behavior that you're discussing.
Well, and I love the idea of a big monster, because one thing that so often is done, especially in Europe, is we compare smaller European countries to the United States. And that's it's just not accurate, and it doesn't work. However, smaller independent European countries can be more flexible. They can innovate. And Finland, I think, is doing an amazing job doing that. And one of the things I love is you guys are just seeing what works best. You're bringing people together and you're completely ignoring how this system was.
Yeah, well, and especially over the last...
Oh, I think you got to bring it a little bit closer. Oh, no. Bring it.
Hello? Nothing?
Nothing. Keep it. I think it's on, but I think you just need to bring it a little bit closer to your face.
All right.
Yeah. Now it's
There you go.
Okay,
All
perfect.
right.
Yeah. So, so being small always has its benefits of being able to move fast if you just have the right individuals. Now, I'm no expert on the system itself, but it's been really amazing to see how during the past few years we've seen really an accelerated interest from the professional side to work with these new solutions. And that really has its benefits. And in digitalization itself, I think that Finland is really far compared to the other, well, Nordic countries, but then the rest of the world. And the benefits, again, they come from being small. In general, it's interesting to see where we're going now, but also I represent more the startup side, and the access to the professionals is improving all the time. So we will see more and more meaningful solutions.
Definitely, definitely. Well, one of the things that I hope, and I don't know what you guys think about this, but I think while the US is a monster, the US is really good at learning from other people's successes. And what I hope from Digital Health Days and all the innovation going on in Scandinavia and the Nordic countries, that when you guys, I'm going to say when, you're successful, the US says, great, let's put that in. Because we love to innovate, we love things that work, and that's what I'm really hoping that comes out of this kind of thing.
I think I actually have to add something to that. We shouldn't see digital health as a competition, who is the best in the field.
No.
We should see it as a collaboration. Bring each other together. The digital world does not know any boundaries, so let's work together and make this into a success.
I love that. Yeah, let's finish there. Thank you guys so much.
Thank you
Thank
so
you.
much.
It was a treat. We're
Yes.
going to do a little wrap up with Donnie and Dina, and
Yes.
we'll see you at the mingle and the drinks.
We'll see you
outside.
then. Thank you.
Thank you
Thanks,
so
guys.
much.
Thank you.
Thank you.